All right. Welcome to week 5. Yes. This week we're going to we're going to dabble a little bit into hospital billing, which would be the inpatient component of the revenue cycle. I'm going to go ahead and share my screen. Again, I have my own specific study guide that is just to complement and support your included week 4 and 5 study guide. Again, all of these resources are going to help you with this week's theory exam. Remember, this week's theory exam covers both weeks 4 and 5 chapter readings. Okay. I'm going to go ahead and share my screen here. This presentation is inside of your week 5 resources, and so is the accompanying study guide. All right, up first, let's talk about the National Uniform Billing Committee, the NUBC. The NUBC is responsible for developing data elements that are reported on the UBO4 claim form. This committee was formed by the American Hospital Association back in 1975. And again, institutional provider. Institutional means that the patient is in an inpatient setting. They have been formally admitted into a institution, whether it be a skilled nursing facility, a hospital, inpatient admission. Those represent institutional providers. All right. Speaking of facilities that would would be part of institutional billing, other facilities would include a rehabilitation center, outpatient surgical centers, skilled nursing facilities, just to name some additional resources, or excuse me, institutions that would bill out using a UBO4 claim form. Just remember, the use of this claim form, again, is in situations or places of service where a patient is going to be for an extended period of time. Must be over 24 hours to be considered admitted and verify, or excuse me, not verify, but constitute the use of a UBO4 claim form versus the outpatient setting that would use that CMS 1500 claim form. All right, up next, the question is, how many diagnoses can be listed on the UBO4 claim form? Well, there is room for up to 10 diagnoses, 10 diagnoses. Something that's unique about the UBO4 claim form is that there are 81 fields. They're referred to as form locators, just a little bit different than that CMS 1500 claim form. But again, up to 10 diagnoses can be listed on a UBO4 claim form. All right, let's talk about the charge description master. So if revenue is the lifeblood of any healthcare provider organization, the charge description master is its financial heart. Very similar to what we call the master fee schedule in the outpatient setting. In the inpatient setting, we call it the charge description master. Now, what's interesting about the charge description master is that there will be several different department codes that are applied because in a hospital setting, every department, such as the pharmacy department, the radiology department, they're all separate departments that come together to supply different services in different forms to a patient that is, again, has been admitted to a hospital. Whereas in an outpatient setting, right, all the services and supplies are supplied in from one single department, okay? And we don't separately bill out for, say, for example, like gauzes and supplies like bandages. In an inpatient setting, all of these separate services that are being supplied by separate departments should be accounted for. So that is another reason why we have so many additional fields on a UB04 claim form. So on that charge description master, there's going to be department codes, okay? These department codes refer to the specific ancillary department where the services were performed. There'll be procedure codes. So again, these procedure codes you can see on my example here. We use the same type of codes. So the procedure codes are a internal ID to represent a specific service that is rendered. Next to any procedure code will be a service description. That would be the narrative description of the service, supply, or procedure that was performed. There'll also be revenue codes. So revenue codes are used on the UBO claim form to tell the insurance company the department that supplied the service. And then lastly, there'll always be a charge amount. And that charge amount is the dollar amount the facility charges for each procedure, service, or supply. All right, up next, let's talk about those revenue codes. So revenue codes are 4-digit codes that identify the department that supplied the service. So it's the use of revenue codes that allows hospitals to use the same CPT code in multiple departments because it will show which department the services were provided in. So when putting these revenue codes on the charge master, you would add the correct revenue code to the CPT code you were going to use for that particular department. Again, just like we talked about how a lot of this information or data is already kind of pre-generated, uh, it's the same thing with institutional claims, right? So the departments that supply certain services, all of those codes are already built in with the charge amounts already built in, and they're ready to be entered or selected to be entered into the UB04 claim form. Just like the CMS 1500, we don't physically see these templates in front of us. We're creating the information and entering the data that goes onto these templates depending on what source, right? What department is supplying the services or supplies, right? So again, a lot of this information is already defaulted in the charge master. And when that revenue or the supply is rendered, right? Whatever department supplied that service, we'll just select that service and it will automatically populate that revenue code. All right, let's talk about ambulatory surgery units. Also can be acronymed as a ASU. So an ambulatory surgery unit is a department in a hospital facility that performs surgical procedures that don't require an overnight stay. So when we talk about ambulatory, I want you to think same day in, same day out, okay? So an ambulatory surgical unit is a department that's connected to a hospital, okay, but can perform ambulatory procedures. Again, this simply means that instead of a patient needing to be admitted into a hospital for an overnight stay, all that would be required would be the use of this suite, like an operating suite, just for the time allowed for to complete the procedure. And then the patient would be picked up by family and then sent home on the same day, or they could drive themselves. So it really depends on the service or procedure. All right, let's get into HCCs. Now, this would be a great opportunity for you to open up your ICD-10 book, go over to those symbols and conventions at the very beginning of your manual. That would be your guide. And then you're going to see a list of ICD-10 CM tabular list symbols. You've got 1, 2, 3, 4, 5, 5 on the left-hand side, and you'll see the hierarchical condition category. It kind of looks like a little purple pill. And I'm just going to read the description of this straight out of your book, okay? And then we'll start breaking it down. So HCCs. The hierarchical condition category was initiated in 2004 for the reimbursement for patients with Medicare Advantage plans. Again, this is very specific. Medicare Advantage plans, we'll talk about, we call this Part C. So if a patient has Medicare Part C, this would be considered an Advantage plan. So what does the advantage of Part C mean? It means that that patient's Medicare benefits for hospital, which would be Part A, and that patient's benefits for services supplied in the outpatient setting, which would be their Part B benefits, are combined, okay? Part A, hospital, Part B, outpatient services, are blended and are managed by a single organization or a healthcare company. Advantage plans, the advantage is that the patient doesn't have two separate components for, again, depending on where their services are supplied. It's one single billing, or excuse me, billing is under one single entity. So, and that entity would be their commercial insurance plan that is supplying the services or the reimbursement for their inpatient and outpatient conditions. Okay, so when we look at this, it says HCC is based on a list of chronic or severity of illness codes that CMS uses to determine reimbursements to Medicare Advantage plans. The HCC risk adjustment factor data is calculated for an entire year of the patient's care. So again, even though the diagnosis itself does not have a reimbursable dollar value like a procedure does, they have to consider how much that patient's chronic condition cost for a full year of care. So all the services, procedures that are rendered or supplied in order to manage this patient's chronic condition. So that is where that dollar value comes in for an HCC condition category. So this patient has, diabetes and hypertension and chronic obstructive pulmonary disease. Okay, so that's 3 separate HCCs. Okay, hierarchy condition categories or diagnoses that would fall into those HCCs. Now that what they're saying is that now that Medicare Advantage plan has to come up with a figure, a dollar amount for how much money it takes, right? So money comes in the form of services and supplies, okay, to manage and treat these patients' chronic conditions over a full year. So they need to get an estimate of that cost up front so they know how to adjust their budget for each fiscal year. Okay. Business of medicine. All right. So I'm going to read my slide here. I broke it down a little bit further. So HCCs is a risk adjustment model, and this model is designed to estimate future healthcare costs for patients. So each HCC, okay, is mapped to a ICD-10 code, for example, COPD, okay? So the HCC relies on this ICD-10 code, these diagnoses, to assign a risk factor or a risk score to patients. So more chronic conditions a patient has, right? One patient, multiple chronic conditions, the higher their risk factors are, because now that patient has comorbidities, multiple conditions that are affecting this patient's care and could potentially affect how long their hospital stays are as well, right? So if a patient has more than one chronic condition that's affecting more than one body system, then essentially all of those conditions are working against each other, these comorbidities, and can affect the care that is supplied and could extend the hospital days or hospital inpatient days due to the risk of complications. So these HCCs, okay, help communicate the patient's condition or complexity of their conditions. It paints a clearer picture of the whole patient. This includes demographic factors such as age and gender. So these insurance companies, the ones that manage that Advantage plan, that Part C, use these to assign patient risk adjustment factor scores. We call them RAFs. They use algorithms. So again, based off of geographic location, so demographics, age of the patient, how many conditions that they have that are, causing these risk risk factors to increase. It could even be that the conditions are not being managed. So, for example, if the patient isn't consistent with their medications, or maybe they've got some type of social determinants of their health that are also contributing to these risk factor scores, such as homelessness, lack of adequate housing, or lack of adequate food, lack of electricity. So let's talk about a patient that may be unhoused but requires a medication that needs to be refrigerated, right? Then that puts them at a higher risk. It's not just about the sickness, it's about that whole picture of that patient. What is putting them at risk? Okay. So, excuse me, in addition to helping predict healthcare resource utilization, these risk adjustment factor scores are also used to risk adjust quality and cost metrics. Again, got to keep repeating this. This is business side of medicine. So accounting for all these differences in the patient's complexities, quality, and cost performance, they can be more appropriately measured. Additional information about HCC coding. These RAFs, or risk adjustment factor scores, are reset every year, which makes sense, right? As the rising cost of healthcare continues to, from the supplies, the prescription drugs, office visits, all of this continues to increase, so do these scores that they need to be readjusted and reset every year as well. So practices need to report active diagnoses annually and chronic conditions. Again, we need that whole picture of the patient. So on a physician side, or the clinical side, the annual wellness is a really great opportunity to capture all of these appropriate diagnoses. So preventative screenings, screenings for risk factors such as depression, maybe even risk for of falling, smoking cessation. All of these different risk factors go into this annual wellness screening. And these HCCs are additive. So again, it's important for physicians to code all conditions that coexist at the time of an encounter or affect the patient's care and treatment. So again, a patient could come in and they could, their chief complaint could be difficulty breathing. But however, they also have, but they may have numbness in their extremities. And okay, so now we've got a patient that has COPD. They're having exacerbated, breathing symptoms, and they're also experiencing numbness and tingling in their extremities due to polyneuropathy and blood clots, right? So now this patient already has some previously identified conditions that are now contributing to this patient's overall wellness. Okay. So again, that's why we have to tell the whole story, right? Chronic conditions and what that patient is being seen for, or what that patient's chief complaint is today. Okay. Because there's comorbidities. Okay. There's other conditions that, again, everything, when we talk about certain conditions, we also talk about, we want to consider the systemic effect, the whole body effect of these chronic conditions. They don't just affect one body system. Again, some of these are systemic chronic conditions affecting more than just one single body system or organ. A little bit more about HCC coding. Again, we're not the ones assigning the HCCs. They're just indicating to us with that little purple symbol that the condition that you're coding falls under one of these risk categories. That's it, right? For us, that's all we really need to know. Okay. So history codes can also be used as secondary codes if the condition or the family history may impact the patient's current care or may influence treatment. So again, I talk about that reference to social determinants of health. So it could also be personal history of cancers. You could also have personal or family history of cancer, or whatever that looks like. Again, that helps support or impacts the current decision for whatever that treatment decision is, or management is. So the documentation, again, this is on the clinician side. This is not for us, but what we need, right, in order to support any codes that are reported out, is that the physician must support a diagnosis. The documentation must support the diagnosis reported. Okay, so that really doesn't change inpatient versus outpatient. Those standards are the same. So the only difference is I'm going to introduce you to a new acronym. So we talk about, last week I introduced you, and the week before we talked about SOAP notes, subjective objective assessment and plan, that breakdown. Now I'm also going to introduce you to a new acronym, MEET. Pretty much the same thing. So the documentation, okay, a good rule of thumb is to document to what's called the MEET principles. So a diagnosis should be monitored, evaluated, assessed, or treated. MEET. And that's what needs to be inside of that chart note. Okay. There has to be, we'll call it the MEET principle. So diagnoses that are not supported by documentation, again, will not be held up in the event of an audit. So the diagnoses influence our care, our treatment. Without the diagnosis supported by documentation, again, that puts you at a risk of an audit. So, coding to the highest level of specificity and ensuring that the diagnoses are properly sequenced on a claim is what we can do, right? This is where we influence that claim, right? The provider supplies us the information, but then we can take that last look, right, before that claim goes out the door by just reviewing the diagnosis that that provider supplied us and ensuring that they're in the proper sequencing. Some things to consider when selecting the appropriate diagnosis code. Type and underlying cause. So I added in here examples of type 1, type 2 diabetes due to underlying condition. It could be also due to, genetic defects, whatever that looks like. The severity of the condition, so words like exacerbated, complicated, um, the site, location, laterality, again, any associated comorbidity conditions, if there's substance use or abuse, substance exposure, such as tobacco, alcohol, drug use, etc. Okay. I added in some examples to hopefully help clear up any confusion with these risk adjustment factors. So I've got two, my next slide has the same patient, 60-year-old, 68-year-old female, but you're going to notice some slight differences in her conditions and her risk adjustment total scores. So my first example is a 68-year-old female patient with type 2 diabetes with no complications. She has hypertension and a body mass index of 38.2. So they have, and these are just sample scores, okay? So based off her age and gender, they put a risk adjustment factor score of 0.323. No complications, type 2 diabetes, risk adjustment factor 0.105. Essential hypertension doesn't have a doesn't have a risk adjustment factor score, so we'll just keep that as 0. And her BMI does not put her at risk either, so that's going to also have zero points assigned to it. Now, total risk 0.4. Let's look at the same gender and age patient with a little bit different type of complications. My next patient has type 2 diabetes, but with diabetic neuropathy, polyneuropathy, hypertension, morbid obesity, and CHF, congestive heart failure. Okay. So age and gender demographic risk factor score doesn't change, but then start to notice how the type 2 diabetes, because it is has a systemic effect, now she's got a higher risk adjustment, or excuse me, risk factor score. Her morbid obesity, again, increased her risk factors. Her heart failure, congestive heart failure, also increased her risk factor. And so that disease interaction of diabetes mellitus and congestive heart failure also adds to her overall health risk. So her total risk with these specific conditions would put her at a 1.3. So again, everything is taken into consideration, which is why it's so important that we're representing our patients, right? Demographic wise, age wise, date of birth, all of these things come into and contribute to these scores, these risk factor scores. So our coding, or it isn't our coding, our physicians are supplying us these diagnoses, but we can see how the value, right? It goes beyond telling the story of what's going on with the patient. Depending on that patient's insurance, this also has to be calculated into how much it's going to cost to manage this patient's care. And that includes hospital stays too, right? So these disease interactions, these comorbidities, increase her length of stay in a hospital if she was, admitted. We have to take into consideration even down to medication management, right? We can't have medications that may have contraindications, right? So again, more risk, more complications, more chronic conditions that are, different demographics and age groups. All of this contributes to this annual out of pocket. Okay. All right, let's talk about the DRGs, diagnosis related groups. So similar with the HCCs, kind of go together, okay? So now we've got groups, diagnosis related groups that categorize patient with respect to diagnosis, treatment, and length of hospital stay. So you can see what goes into DRGs. So DRGs, the assignment of a diagnosis related group depends on the variables of what the patient's principal diagnosis is. Are there comorbidities or secondary diagnoses? The surgery that's performed, um, the patient's gender, age, and also discharge status. So all of these, the assignment of a diagnosis related group, right, all depends on those variables. And again, this is not something that we're doing. It is simply how the insurance company is categorizing these specific patients, okay? And again, this all comes down to how that entity or organization pays for services. We have to estimate the an annual dollar amount when patients have these types of comorbidities or diagnosis related groupings. So DRGs, define a DRG. It's diagnosis related groups categorize patients with respect to diagnosis, treatment, and length of hospital stay. All right, up next, let's talk about a cost outlier. So, when a case cannot be assigned to an appropriate related diagnosis related group, DRG, because of an atypical situation, the case is referred to as a cost outlier. So, let's break this down. A diagnosis related group payment, okay, is based on the care that is given to and the resources used by a typical patient within that diagnosis related group. When the cost of treating a specific patient is unusually high, due compared to a typical patient with that same DRG classification, the case is referred to as a outlier. Okay, an outlier. Bonus information here, a little bit of extra. Cost outlier threshold, the definition of this is the dollar amount that a claim must exceed in order to be eligible to receive an outlier payment. So basically what you're asking for is an additional payment for the excessive services that went above and beyond the typical services and resources given to a patient of the same diagnosis group. Okay, so when it costs more than that estimated cost, now we got an outlier. And how's that hospital going to receive payment for this atypical situation? Okay. Let's see here. What else do I got? Interactive cost outlier tool. So there's resources for us as billers as well. So we have what's called an outlier tool that helps assist in determining the proper billing of your inpatient prospective payment, what we call our outlier claims. And there's a software program that allows the facility to calculate its DRG payment groups. Guess what that name of that software is? Grouper. Grouper is the software program that allows the facility to calculate its diagnosis related groups or payment groups. So again, there's lots of softwares and that help complete this job for us. Okay, all we do is supply the diagnoses that are provided by the doctors, and it will generate this potential cost outlier. How much additional monies were expended, right? And how do we get reimbursed for this? So again, it has to exceed a certain dollar amount before it'll even be eligible for a cost outlier. And there are supportive tools that we use in our billing software in a hospital inpatient setting that will help facilitate the calculation of what these DRGs are. Let's see here. Referring to a DRG, what is CC used to indicate? CC represents complications and comorbidities. Okay, so I added some examples of complications and some examples of comorbidities. A complication would be a hemorrhage or an infection or some type of organ failure or complication after a procedure. A comorbidity would be an additional condition that's affecting this patient's outcomes. Okay, so comorbidities could be diabetes, chronic asthma, emphysema, heart disease. Those are additional diagnoses that a patient has, chronic conditions that are affecting the outcomes of this standard procedure. So cesarean, C-sections, transurethral prostatectomy, so basically that's just a removal of the prostate via the urethra, and a C-section. Those services or those procedures happen all the time for whatever reason. But what adds to the outcome, right, or the that reimbursement is complications, comorbidities. Comorbidities can extend the hospital stay. So can complications. Um, but again, all of these, when we're referencing these diagnosis related groupings, right, what puts this patient at higher risk? Complications and comorbidities. Higher risk means additional reimbursement, right? You have to account for these. All right, let's see here. Let's talk about who maintains the APC, Ambulatory Payment Classification List. That's going to be CMS, the Centers for Medicaid and Medicare Services. So hospitals can receive several separate APC payments from a single patient visit. So the ambulatory payment classification bases payment on procedures. So basically anything used during a procedure is a billable expense, and it's up to the hospital's team of coding specialists to determine which APC codes are appropriate. So the ambulatory payment classification is the government's method of paying facilities for outpatient services for the Medicare program. All right, more acronyms. Now let's get into the PPS, the Prospective Payment System. So the PPS is a method of reimbursement that establishes the rate of payment to a hospital before services are rendered. Again, they already estimate if a patient comes in and presents with this diagnosis, this is the standard care. Okay, so they already can they can pre prospectively, okay, determine that expense or what that cost will be. So prospective payment or PPS reimbursement is established before the healthcare services are rendered and monies are expended. So reimbursement is based upon a specific type of PPS, prospective payment system methodology. So when it's pre-established what that rate of payment will be, what it means is that they may have variables such as the patient's length of stay might be over what that estimated length of stay is. Maybe additional services were rendered. Again, we talk about those cost outliers, but it doesn't always necessarily mean that it's going to result in an increase to the reimbursement. It still has to meet a maximum amount before any additional monies are going to be considered for reimbursement, because these are pre-established payment rates. Again, that's how diagnoses come into play in the inpatient setting, right? How much money does it usually take to treat and manage this particular condition? So there's already a pre-established rate of payment before those services are already rendered based off of the typical amount of resources used. Diagnosis related groupings, DRGs, are a type of prospective payment system. So in general, DRG payments cover all the charges associated with an inpatient stay from the time of admission to the time of discharge. So the DRG includes any services performed also by an outside provider. So payments for each diagnosis related group are based on a relative weight. So I also like to refer to this as an RVU. So every service, okay, has a value to it. We also call it a relative I call it a relative value unit, an RVU, or they also refer to it as a relative weight. Okay. So that is the amount of money that's assigned to each service. So the relative weight represents the average resources necessary to provide services for a specific diagnosis. Let's see here. Let's talk about patient control numbers. So a patient control number is assigned to a patient at each admission to a hospital. So a patient goes into the hospital, admitted every other day, they're admitted and discharged. They're going to get a new patient control number every time the patient is admitted. Let's see here. And that is going to go in section or field or form locator on the UB04. 3A, admission date, type, and source. So if the time that the patient was admitted is unknown, we will use in form locator 13, okay, we'll use 99. If we are unsure or if the time is unknown as to the admit time, we just use 99. All right, we talked about this a little bit earlier, those complications and comorbidities. So the question on your study guide is define comorbidity. So comorbidity is the simultaneous presence of two chronic diseases or conditions in a patient. A patient could even have more than two chronic conditions, okay? But that is the basic definition of comorbidity, simultaneous presence of two chronic conditions or diseases in a patient. So because of its effect on the principal diagnosis, the comorbidity typically results in a more intensive therapy or longer hospital stays. Again, we were talking about that example of that combination of a patient that had diabetes mellitus with polyneuropathy and congestive heart failure, right? So again, the effect on the principal diagnosis typically is why there's more extended hospital stays or more intensive therapies required for patients that have multiple conditions or comorbidities. Let's see here. Question 18, when will a hospital bill for patient services? So after the discharge paperwork is completed and has been signed by the physician, that is when a claim for an inpatient stay is submitted and processed for payment. So you got to remember, patients can be in the hospital for, days at a time, weeks at a time, months at a time. So until that patient is discharged in whatever format, right? Discharged to a nursing home, discharged because they, expired, discharged home, right? All of this is the patient's current status at the time of discharge, right? So that, there's been continuous care and revenue has, from different departments and supplies have been, provided during that patient's inpatient stay. So all of that has to be pulled together at discharge. And when I say pulled together, it's, that's when we're assigning all of this and compiling it all of these revenue codes and services supplies and dates of service of their inpatient stay all gets combined onto this claim form. And again, once that discharge paperwork, because there's a discharge status code that has to be applied on a claim form, that's why we can't just build these out for every day that the patient is in the hospital, claim by claim by claim. You have to wait until the end because there's a discharge status code as well. Okay. Let's see here. Next up, let's talk about what per diem means. So per diem is another type of reimbursement. And this pays, per diem means per day, okay? So this pays a fixed rate per day for all services that are performed or provided at a hospital facility. So per diem, this is based on a daily rate for the type of admission and the level of service provided to a patient. So again, it's already accounted for. So depending on the type of facility, okay, and the services provided, they've already got a flat daily rate. So the level of service provided to a patient is going to depend on what they were presenting with. How complicated was the condition that they are presenting with, that's being managed. So that's where that level of service comes in. So per diem is a method of reimbursement that pays hospitals a fixed rate per day for all services. All right. Lastly, let's talk about the OPPS. So we talked about the prospective payment system on the inpatient side. Let's talk about the outpatient sector. So the OPPS is the system through which Medicare decides how much money a hospital or community mental health center will get for outpatient care to patients with Medicare. Remember, even in a hospital setting, we've got ambulatory departments, right, that can supply patients with care, medical treatments, but don't require a hospital stay. Okay. So that is where the outpatient prospective payment system comes into play. Highly recommended video. Oh, I'm not going to play it. I'm going to leave that one for you. It's an excellent breakdown of the differences between your prospective payment systems and your fee for service in that outpatient setting. So definitely take a look at the prospective payment video, and then also this video right here, ICD-10 inpatient coding with review of DRGs, POAs, which is present on admission, and a brief look at HCCs. Melanie Grant is her name, and she is another excellent source of information. All right, so make sure you guys check out those videos. All right, and that is it for week 5. Woo, we are almost there. Reach out if you have any questions, and I look forward to seeing you, and I hope you look forward to seeing me in the next episode. All right, take care.